Hello, everyone. I think we have 32 participants online. And so thank you for joining today this live session of the Medical Mycology MOOC. We're very happy to have you all online and to start this session with, of course, our two directors, Prof. Olivier Lortolari and Dea Garcia Hermoso from Institut Pasteur. Hello, everyone.
Hello, everyone.
Hello, Timothée. Hello, everyone.
So let's open only for a second the see our faces. So hello, everyone. We're glad to be here in the webinar.
Hello again.
Great. So we have a little bit more than 30 people connected. It's 2:10, so I think we can start the session now, if you agree. And so don't hesitate to ask some questions during the webinar. We'll try to answer everything. We also had a few questions on the MOOC discussion on the forum that we will answer today, and also a few questions that some of you had when they registered for the session. So we'll try to answer everything, and also we'll try to keep time in order to give you take-home messages for all chapters that you have on the MOOC. So let's start maybe with the first question that were posted on the discussion. So the first one we had to discuss is about 𝐏𝐚𝐬𝐬 mycosis. That's a question for Prof. Lortolari. Because so somebody asked say that you mentioned in this talk that it was the most virulent dimorphic fungi, and they wanted to know if that means it is associated with higher mortality rates compared to Histoplasma and Thallaromyces.
Thank you very much, Timothée, for this nice introduction. So Coccidioides imitis or Posadacea are very dangerous pathogens to manipulate in the laboratory, with inside laboratory contamination ever reported. So this fungus has to be manipulated in very safe cabinet condition, PSL3. And this fungus is responsible for symptomatic primary infection or acute infection more often than other dimorphic fungi. And the primary infection can be followed by dissemination, even in non-immunocompromised patients. So that's why I mentioned the most virulent pathogen. And it has been selected in the past as an agent for bioterrorism, which means the virulence of the pathogen.
Thank you so much. So if anyone has more question about cocci, you can ask on the Q&A item during the session. The second question we mentioned was about, so we'll change the subject, the topic. This was about galactomannan sensitivity. And we had a few questions regarding galactomannan. One question was about Aspergillus niger sensitivity. And so we said we will talk a little bit more about galactomannan today.
So thanks, Timothée. Galactomannan detection is very important for the diagnosis of invasive aspergillosis. And as soon as antigen is positive, the question is, does the patient have invasive aspergillosis? This test is almost negative in all forms of chronic aspergillosis. That is also important. And among invasive aspergillosis, the test is most often positive in case of neutropenia, meaning angio-invasion due to the fungus. However, galactomannan detection can be found also during other fungal infections, such as disseminated fusariosis, for example, such as Therapeutic infection, such as Histoplasma either capsulatum or 𝐏𝐚𝐬𝐿. So it's not specific for Aspergillus. It's negative in case of Meteor Mycosis. So please remember that it's a marker of angio-invasion during invasive aspergillosis.
Mm-hmm. And we can add that this galactomannan is detected even in different Aspergillus species, including Aspergillus niger, for example, or other species in the complex nigri.
Yes. So it's one tool very useful in the search for fungus strategy.
Thank you for the very comprehensive answer. I think we had a few questions on the during the course for those who have already seen most chapters. We had a few questions about prophylaxis in hematology. I guess we had answered most questions on the MOOC itself. So please don't hesitate to go. I'm just trying to, I will share my screen just to show you that you, for those who are not aware, you have a few questions that has been answered directly on the forum, and so you can go there to, so you can see all questions and you can see all answers. So don't hesitate to look at them. And if you have any other questions regarding prophylaxis in hematological patients, please ask during the session. So I think now, Dea and Olivier, we can go through the questions that were posted on the MOOC on the session registration. So the first one was how to detect invasive fungal infection as soon as possible.
I will start the answer. So first of all, it's very important to think that the disease can be caused by a fungus. If you don't imagine that the disease is caused by a fungus, you will never find it because you will never look for. So after having thought on invasive fungal infection or superficial infection, you have to perform a direct examination, which means microscopy, and Lea will comment about that.
So it's important to keep in mind that direct examination is it's a very important part in the identification or in the diagnosis of fungal infections. I want just to remember some, for you to remember some elements. For example, we know that this fungi can be seen by direct microscopy techniques. Okay, so we know that we can do it without any processing or staining, and we can do this by examining the soft tissues or pellets or prints that will be helpful to distinguish, for example, yeast from Histoplasma capsularum that are different from Histoplasma du Bois from bronchoalveolar lavage, for example. Or with these direct examinations, we can also observe, I don't know, the polysaccharide capsule of Cryptococcus neoformans out of the CSF. And also, for example, the particular morphology that we can find in blastomyces yeasts, specifically by their large size or their broad base single bud that they have. etc., etc. So this is for direct examination without any processing. And you know also there are direct examination with processing or staining. And this is also important because it's going to help us in the direct examination to be more, to have a clearer visual observation for example, the solutions that we use with like 𝐏𝐚𝐬, that it's with potassium to clear the specimen, and this will increase your visual contrast and you will see better the fungus. We can use India ink to have this to visualize all the encapsulated organisms, or use chlorazole black solution. This will be helpful, imagining if you want to distinguish the mycelium from Mycorrhizal and from Aspergillus, that are different, and this is also important. And finally, imagine the chalcofluor white that we can use with a fluorescence. This is a fluorescent brightener, so it's also important in direct examination. So keep in mind that this is a very important part of the process.
And direct examination is also important to select the type of PCR or any molecular tool, because the positivity of molecular tools is highly dependent on the presence of the pathogen as early as microscopy is performed. In terms of as soon as possible means that you are, as a mycologist, and especially medical mycologist, able to dialogue with radiologists and clinicians. And clinicians, don't forget that there may be ICU physician, hematologist, transplant physician, pediatrician. So you have also to adopt a strategy, to adapt the strategy to the center's capacity. Of course, if you are the opportunity to perform CT scan, MRI, PET, CT, antigen detection, and molecular tools detection. It's a very complete strategy. And don't forget that even in low resource area, microscopy is very, very useful.
Okay, thank you. Both. So we had another question, I think, from the same participant, which was, when it comes to fungal infection of
Long throat, ENT.
What are the visible symptoms?
I may say that sinusitis can be revealed as any sinusitis by pain or fever. What is particular is to look for necrosis, either in the sinus cavity or in the skin nearby. Again, think about fungus in case of difficult to treat by antibiotics sinusitis. And the particularity is the local regional invasion and the destruction of the bone structure surrounding sinus cavity. For otitis, obviously hypoacusia, vertigo, and again pain and fever, and even central neurological symptoms can reveal the disease. And for mouth and throat, thrush, necrosis in case of a mold infection, and particularly Meteor Mycosis. And don't forget the chronic ulceration or subacute ulceration due to paracoccidioides and Histoplasma capsulatum, variety capsulatum.
Okay, thanks again. So now we have two other questions from another participant. So more for mycological test themselves. So the first one is, in the case of a dimorphic fungi, what is the procedure for them to express the yeast-shaped form?
Yeah, that's a very nice question. Well, we don't do a lot the conversion from mycelium to yeast in dimorphic fungi because it's a very it's not as the efficacy is not like 100%, it's like even 50% sometimes, for example, in histoplasma. But first of all, remember that dimorphic fungi are fungi that belong to the risk group 3. So they, as we have said also, they have to be manipulated under safe laboratory conditions, for the exception of sporotrichs 𝐏𝐚𝐬𝐭𝐞𝐮𝐫. And this conversion to yeast phase that will require special media, like we can name the brain heart infusion that it's used, BHI, that can be supplemented, for example, with other nutrients like glutamine or sheep blood. And then you can culture your dimorphic fungus, and you can wait an incubation of 2 or 3 weeks, 2 to 3 weeks, mostly for at a temperature of 37 degrees, and it's good to put some CO2, 5%, so it will grow nice like that. Other media can be used, like chocolate agar, for example, that is heat-treated blood agar, or even the saburo dextrose agar that can be useful. So to obtain really the yeast form in a better condition, you should do subcultures for these serial subcultures, so you can optimize the conversion.
That means, again, for the final diagnosis of the histoplasma species, that it's important to know that culture is similar with both pathogens. And even molecular tools recently available cannot distinguish between Duboisiae and capsulatum. So you have a key role with microscopic examination in order to diagnose small yeast or larger yeast in African, so-called African histoplasmosis due to Duboisiae.
Okay. Then this was a more specific question, but also very interesting about nail infections. So the question was, in the case of nail culture, is it correct to report the genus Curvalaria bipolaris Cladosporium rhizopus trichoderma in case of isolating a single colony?
Well, first of all, in this question, the genus that are named, there are not very common agents involved in onychomycosis. So for the most common fungal agents are dermatophytes, anthropophilic dermatophytes like rubrum, trichophyton rubrum, and Anterdigitale, or other pseudodermatophytes such as Scopulariopsis or Neocytalidium. Of course, yeasts, Candida albicans, and and other non-albicans species, and in molds, Fusarium or Aspergillus, Onychocola canadensis. But in the clinical point of view,
so I think it's important to know that among immunocompromised patients, and especially neutropenic ones, the nail infection can be the source of a disseminated infection, and that has been well illustrated by our nice colleagues from Brazil in Rio. They have demonstrated the clear correlation between nail or interdigital infection due to Fusarium and the subsequent occurrence of dissemination with a positive blood culture. It's also important to realize that chronic nail infection can reveal immune deficiency, and that has been well characterized for HIV-infected patients, but also primary immune deficiencies such as STAT1 mutation in case of chronic Candida nail infection.
And I think we can add something about when we are looking at a single colony of all the genus that were mentioned in the question. It's maybe very important to see if you have a direct exam that is positive, that it's a real infection and not only a contamination.
Yes, thank you. So yeah, thank you for this very interesting question, which was quite specific, but also please note, as Prof. Lortolari said, that you must think about more disseminated infection in case of nail infection for some patients. So now a question was about literature and any mycological references. So I think most speakers in their presentations have cited a lot of references that you can, of course, go through. But also somebody asked if there is kind of a Bible of mycology. So I think we have a few references here.
Yeah, we can post them also in the forum. So more specifically, yes. So for mycology in descriptions, for example, we use a lot the Atlas of Clinical Fungi from 𝐏𝐚𝐬𝐿 and collaborators. So this is a very, very nice book with more than 700 descriptions in the last edition. It's the 4th edition. So yes, this is very, very helpful. All the medical important fungi are named here, and there are a lot of references, and it's a really good book.
Also, for more medical information, please read Oxford textbook Medical Mycology, or Medical Mycology by 𝐏𝐚𝐬𝐭 and Bennett, or even a very nice book which is cited as Essentials of Clinical Mycology. But I want to add with Dea Garcia-Hermoso that also one way to read the Bible of mycology would be to participate to the future course of medical mycology at the Pasteur Institute in 2023 spring period. So it's very nice to come to Paris in March or April, and it's even nicer to learn mycology with us, and we would be very pleased to welcome you.
Of course, and this is a course that is very complete with bench work and theoretical sessions in mycology. So yeah, we'll put the information also in the MOOC later on.
Okay, thank you. So to come back to more epidemiological question about antifungal resistance. So somebody asked if changing human lifestyle can have any role in antifungal resistance for fungal infections, of course.
I think both of us can say yes. There are two famous examples. The first one would be the occurrence of azole resistance in fumigatus, in Aspergillus fumigatus, due to the large quantity of poisons or pesticides, which are antifungal agents in the environment, especially agriculture. So that has been well documented, especially in Netherlands, but also in other countries, the link between environment and the acquisition of resistance among Aspergilli, especially fumigatus, before the occurrence of human infection. The second one is the dissemination of Candida auris in case of international traveling. Don't forget that the world situation is very bad now. Almost all countries and continents have reported Candida auris infection, especially in ICU. That means that the world map of Candida auris infection cannot be changed due to the magnitude of the dissemination.
Thank you. So all these interesting topics are well described. So I've put the map here that you can find also in the session from the MOOC, which was whom speaker is Evelyn Snelders from the Netherlands, and so these two main issues have been detailed by her in this session. So for more details, please go to the session. So I think we've gone through all main questions you had before this live session. I don't know if you so I don't think there's no. Yeah, we have one more question on the MOOC today. I mean, about a scientific question. So there's another more technical question we'll answer later on. So Dea, maybe it's for you. In case, I don't know if you see the question.
I can see it. Is this ammonia? Modest
Yes.
ammonia? Yes. So in case to obtain, yeah, you can read it. Go ahead.
In case to obtain pure culture colonies, which dilution can we do and how to do it works?
Okay, if we're talking about the molds, you know, if you're talking about filamentous fungi and you want to obtain a pure culture, you should do serial dilutions, 10 serial dilutions, 10-fold serial dilutions, so you can get isolated colonies. And these you can put your culture in a tube with water and do your serial dilutions and then plate them. And the objective is to have a single colony, so you can then subculture anywhere, and you will be sure that your culture is pure. So that's the way we do for the molds. For yeast, it's easier. So you can use chromogenic media, as it was told in the session of yeast identification in the MOOC. So you can use chromogenic agar, and then you can just plate them and obtain cultures, pure cultures. Yeah, I can add something more for the dilutions with molds. If you're dealing with Aspergillus, for example, or Penicillium, it's important to use as a solution water with some detergent. So you can have the hydrophobic conidia. You can get them better in your solution. It will be homogenized, and then you can do your serial dilutions. It's important to add some detergent to the, like Twin, for example, Twin 20 to your sterile water.
Okay, thank you, Dea. I've just seen a question that about recording the session. So yeah, this session is recorded, so it should be available later for those who joined late. So I think now we could probably go through main take-home messages from the course that we have prepared for you. And of course, if you have, so if participants have other questions that you want to be answered live, don't hesitate to post them. So
there's one question that I'm looking at about the organization and the MOOC. Have you seen the, okay. So for example, in HIV-related fungal infections, there is a talk about endemic mycosis. So yes, there's a talk about endemic mycosis. Is that the question?
Yeah, so I think this question is related to the chapter's distribution on the course. So I guess yeah, some topics have been organized under the HIV-related fungal infection chapter, and this will be probably changed for the next session to have more homogeneous presentation of invasive fungal infections.
So I think we can go to the.
But just there, that we have a new question, which is: do you have data on the prevalence of dermatophyte resistance in Europe, especially for T. indotinea occurrence? I don't know if you can see it.
Yes.
Yes, to answer to the prevalence is very difficult because the diagnosis of such resistance is not performed everywhere, first of all. And we start to see this kind of infection coming from the Indian continent in Paris. So yes, it exists in Europe as imported cases, mostly from Indian continent, but no data, to our knowledge, no data yet on the prevalence precisely.
Mm-hmm.
Great, thank you. Sorry, do you want us to? Yeah, I think we can go through the take-home messages. So we wanted to try to give you some very short and pragmatic messages about each session. So, so we'll start with the chapter 1. So I don't know if everyone has been able to see all sessions, but it's not a problem. Even if you will see, you will learn about sessions later. It's still useful. So the chapter 1 is what are fungi, and of course the first sequences are about ecology and burden.
Yeah, what can we say about this session? In few words, I think it's good to remember that all the exposure to fungi that we have is possible by inhalation, inoculation, ingestion. There's also the fungi that are also changing. The ecology is changing depending on the geographic area, right? That's for the first. That's for the first session. If we, yeah, you want to add something?
No, I just wanted to go further.
Yeah, go.
Okay, so fungal sequence 1, 2, fungal cell structure and growth. So we think that it's important to remember that the fungi are eukaryotic cells with 𝐏𝐚𝐬𝐭𝐞𝐮 and 𝐬𝐚𝐬𝐭 as cell wall components.
Important, the aerobic condition also for fungi. It's good to remember that also. Concerning the classification and taxonomy, I think it's good to keep in mind that most of the medical important fungi that we have, they belong to the ascomycetes, so to the 𝐏𝐚𝐬𝐭𝐞𝐮 phylum. So this is what we can take as a message. And then, for example, the sexual and sexual development that you saw in the first, in the end of the chapter 1. This is, I think, most of the fungi that you see, that you examine, they only develop, most of them, they develop only the asexual form, okay, in culture. And so gonidiogenesis is important also for this, to like as a key element to begin or to determine the identification of your fungus. For sampling, in chapter 2, when we get to the identification of fungi, we have this sequence of sampling, transport, and storage. What can we keep in mind is suspicion of this of the fungi that are classified as BSL3, risk group 3, should be manipulated in safe laboratory conditions, as we already mentioned. The sequence about culture, I think that selection of the culture media and the temperature is going to influence in your the sporulation of your fungi, and this is good to know and to keep in mind that fungi can grow in different media, and you can choose the media depending on what you want to obtain.
Regarding antigen detection, we want you to remember that cryptococcal antigen is the most reliable microbiological test ever created.
We have seen advanced methods in sequence 2.5, and we can say that the new methods involving next generation sequencing can be and are going to be very helpful to understand outbreaks and the evolution of fungi. Yeast identification, mold identification, just you have to remember that the best way to identify them is by using a polyphasic approach, so combining phenotypic characters and molecular characteristics.
So when we move to antifungal host immunity in the sequence 3.1, we want you to remember that antifungal immunity includes both innate and adaptive immunity, and that means that there are specific cells and mediators, and these cells and mediators are very important for the defense against fungi. Regarding the sequence 3.2, we want you to not to forget that you have always looked for an immunodeficiency in case of unexplicated invasive fungal disease. So we don't want to see you dealing with invasive fungal disease in immunocompetent patients. In fact, these patients are obviously immunocompromised, even if the technology does not allow yet the diagnosis. Regarding endemic areas, we want you not to forget that the diagnostic strategy has to be adapted according to visited areas. So no need to look for histoplasma if you don't live outside Paris. Even a long time after, and our record in France is 56 years after the departure of the endemic area with a diagnosis of histoplasmosis at the age of 80. And regarding hospital-acquired fungal disease, we want you to remember that hospital outbreaks can be due to yeast and to molds, and molds even in pediatric departments. We have contamination of the material which are able to create, unfortunately, hospital outbreaks.
We get then to the chapter. Yes, or you want to say?
Yeah, that's fine.
We get to the chapter 4. So antifungal drugs, classes and mechanisms of action. Of course, just for you to remember that systemic antifungals have different targets. That when you are using in antifungal susceptibility testing, as in sequence 4.2, remember that the clinical relevance of susceptibility testing results is going to depend on the fungus you have.
So it's not because MIC value is high, first of all, from a microbiological point of view, that the fungus is resistant. To speak about resistance and sensitivity, you need to have breakpoints well defined by CLSI or UCAST. And even with breakpoints, the clinical relevance has to be discussed case by case.
And some of the, also to remember that some molds, for example, they have intrinsic resistance. So just to know them before.
Yeah, for clinicians, I think the main message is that you can't do what you do with bacteria and bacteriology antibiotics resistance and susceptibility. You can't do the exact. You can have the same process for antifungals and fungi.
So regarding antifungal resistance mechanisms, we want you to remember that the burden of resistance is mainly on azole antifungals. So that means that resistance to echinocandins obviously does exist, but is more rare. Resistance to flucytosine can vary according to the yeast, and resistance to amphotericin B is extremely rare. Even we don't know really if it does exist. we have a proposal for therapeutic drug monitoring. So echinocandins and amphotericin B should not be monitored by a therapeutic drug monitoring. So that means that TDM has to be performed for most of triazoles, except for fluconazole in clinical practice. For flucytosine, that's it. And regarding mastering antifungal therapy, we want you to try to have an antifungal therapy tailored to each patient, taking into account the fungus, taking into account the host characteristics, the renal function, the liver function, if the patient is neutropenic or not. So all this information you can read in the Mycology Bible.
And what about the burden? Burden of HIV-related mycosis remains worrisome. This is in.
I'm sure you know that more than 250,000 cases of crypto are observed in HIV-infected patients, with 3-4 of them in sub-Saharan Africa. So it's a huge, huge public health problem. Regarding prophylaxis of IFD in hematology, so it's a very broad topic, and the words we have selected is antifungal prophylaxis in hematology is entering a new era with posaconazole. So posaconazole is crucial for the patients having induction of myeloblastic leukemia and those with GVHD.
Pneumocystosis in the session of pneumocystosis is the incidence in non-HIV patients is increasing. That's what we want you to remember.
As we already mentioned, cryptococcosis is considered now the leading cause of acute meningitis in sub-Saharan Africa, especially in the southern part of Africa. And regarding endemic mycosis, it's important to note and remember that endemic mycosis can reactivate a long time after returning from an endemic area at the time of any immune deficiency being diagnosed.
For candidiasis and dermatophytosis, what we want you to remember is superficial fungal infections should be first treated with topics. Tropical infections, tropicalcutaneous mycosis, they will need antifungals and sometimes surgery. So keep in mind this. While for neglected infections such as mycetoma or chromoblastomycosis, but the fungal origin, for example, for mycetoma should be identified without delay, and think, of course, of skin cancer in old chromoblastomycosis lesions.
So we move now to the chapter 7, invasive fungal diseases. So fungemia first, meaning the presence of fungus in blood, to be clear, the fungus being a yeast most of the time. It's important to remember that one positive blood culture from any yeast should always be treated with antifungal.
Yeah, sorry. And for aspergillosis, we can remember that 90% of invasive aspergillosis are pulmonary.
What about mucormycosis? We think that mucormycosis should be differentiated from invasive aspergillosis due to therapeutic issues. For example, voriconazole is inactive against mucorales, and prognostic issues.
Remember, for emerging yeast infections, that emerging yeast may have multiple resistance to antifungals. okay, such as Candida auris, for example.
And what about emerging mold infections? We want you to remember that emerging molds can be responsible for either sinusitis, pulmonary lesions, mostly nodules, and disseminated forms.
So this is all the take-home messages that you can have afterwards, like Timothée, and we put it on the forum.
Yes, sure. We'll make sure that you have that on a single doc.
Yeah, and this is only for you to remember. This is our only key elements. They are not. They will not cover the whole thing that you've seen in the videos, but it can help you remember and take the best for each of the sessions.
And if you want to learn more take-home messages, please join us in 2023.
Remember that.
In Paris.
And we will post it also that the MOOC will be a pre-requirement for the course that we are organizing at the Institut Pasteur in 2023.
And for
so you'll have, oh, okay, sorry.
For those who speak French, there is also another diploma, which is called Diplôme d'Université de l'Université de Paris. So please join us if you are clinically oriented.
Okay,
you
great.
To say something, Timothée?
Yeah, no, I think for the pre-qualification, so we will post more details shortly on the MOOC discussion. I can see somebody saying that he or she attended that course in 2013-14 session, and they strongly recommend it.
Oh, that's nice.
So yeah, so we will post shortly more details about how this MOOC can help you to be qualified for the 2023 course in Paris at Institut Pasteur. But of course, this will probably be related to the certification of the MOOC. So you will have to pass the exam. So I can just remind everyone that the exam session will start on the 3rd of December until the 16th, I think. So you have a few details about how it goes on the course. And to find more info about this course in 2023, this is a question right now. So you will find more information probably next year on the Institut Pasteur website, right there?
Yes, everything is going to be in the Pasteur website, of course.
Thank you.
Timothée, are there new questions?
No, I guess we don't have any new questions right now. So if there is something coming.
If they want to ask questions afterwards, they can post it on the forum, and then
Yes.
we can answer them later on. So
we have something right now, which is, do you have any information about veterinarian fungus? And we have a question about the 2023 Pasteur course, which is a course going to be held in French only? So I have the answer, but no. It's an international course.
It's in English.
English only.
In 2023, it's in English and it's in Paris. No. For veterinarian, no.
Regarding veterinarian infections, there is a particular session dedicated to animals' fungal infection during the famous medical mycology course of Pasteur.
Okay.
How many people joined the MOOCs?
The webinar
The,
or the MOOC.
So the webinar today, we have, I think we had 43 participants at the most high. And on the MOOC, I think we have something like 2,600 people attending the MOOC this year.
Okay. Thank you very much.
so thank you very much to the audience. And thank you very much to our community
Manager.
who was very interactive.
Yeah.
Thanks so much for that.
Thank you both.
See you soon then. And continue to look at the video and the MOOC, and have a nice one. Bye-bye.
Bye-bye.
Goodbye.
Ciao.